All right, guys, good afternoon. This is Jeremy with the Hospital PT, and filming outside on my porch right now. I think last Friday was the first day of spring, so if you hear birds and different types of animals and that type of thing, we live right up next to a state forest, so it can be pretty active at times. So uh, this video can be, it may be a lengthy one. We're covering a topic that is near and dear to everyone's heart and brings about a lot of emotions, lots of thoughts and lots of feelings from folks, and that's the topic of insurance. Okay, and why insurance may deny rehab placement or skilled nursing placement for your loved one or yourself when it's pretty clear that you would benefit from it. And so, if you or your loved one has been told that you need rehab, right, but insurance denied it, what you need to know is that does not mean that you don't need it. What it does mean is that from the insurance's perspective, you or your loved one do not meet the criteria that they have that would say that you qualify for something like inpatient rehab or a skilled nursing facility or some other tertiary care facility. And so once you understand the criteria, which we're going to talk about in a good bit of detail today, once you understand that criteria, you can increase your chances of either achieving an approval or appealing a denial and being successful in getting approval to go to the type of care facility that you need. And so if you don't know me, like I said earlier, my name's Jeremy. I'm a hospital-based physical therapist, right? Part of my job and what I do, in addition to helping people, get mobile again, recover again during their hospital stay, a big part of what I do in the hospital is to assist the care team in determining what is the next best level of care for this patient. And so every single day, guys, I see people that clearly need rehab or skilled nursing care, and they're denied by their insurance company. And there are a multitude of reasons for this. And I don't want this video to become where we kind of go down rabbit holes, right? So I'm going to cover things at kind of a general level and give you some appreciation for what insurance companies look for, specifically Medicare Advantage plans, because the truth is that most private pay insurance plans or companies often follow really closely to what Medicare guidelines are. Okay, and so let's explore what insurances look for, right? And we're going to start by looking at Medicare. And so this is considered section 1 of the video. So what does Medicare actually require? And so for traditional Medicare, rehab approval is based in general on one thing, and that is medical necessity. And so and that is determined and facilitated by your physician. And so your physician that is overseeing your care in the hospital, they need to certify that either you or your loved one needs intensive rehabilitation that will require ongoing medical supervision from a coordinated care team inside a rehab hospital, right, or a rehab facility or a skilled nursing facility. Okay, and those two things are different. Inpatient rehab and skilled nursing care are two different things, and we will explore those here in just a few minutes. And so, and that's where we're going to get a little more specific. So to qualify for inpatient rehab, documentation must show that several things, okay, follow with me here, that the patient needs multiple therapy disciplines, so that's PT and OT and speech therapy, or some combination of those three, okay? It doesn't have to be all three. Typically what we see is most of our patients, they require 2 of those disciplines, okay? So they must require multiple therapy disciplines. They have to demonstrate that they can tolerate 3 hours of therapy per day or about 15 hours a week, okay? They have to require close supervision by a physician. Now, what that might mean is the patient has some sort of blood work issue that needs to be monitored daily, some sort of blood pressure is so labile that it must be monitored daily. And those are just two kind of easy examples of what would require a physician's supervision closely, okay? And also, and here's one that's a little more abstract, they should be expected to make a measurable functional improvement within a reasonable amount of time. Now that's vague on purpose, okay? And that's a difficult thing to ascertain at times, but that is why your rehab staff functions at the hospital. Or that's like, for instance, one of the jobs that I have is to determine, do I think, based on that person's prior level of function, so what they were capable of before they came to the hospital, and based on what has happened here at the hospital, and based on what they are demonstrating as their current level of mobility, do I think, or do we think that that patient stands to gain measurable functional improvement within a reasonable amount of time? And so also, in addition to those four items, okay, so again, to cover them again, multiple therapy disciplines are required. They can tolerate 3 hours of therapy a day. They require close medical supervision by a physician, and they are expected to make a measurable functional improvement in a reasonable amount of time. Those four things. They can be required to have a pre-admission screen, a rehab physician actively managing their care, and an interdisciplinary team plan. So if a patient cannot tolerate the appropriate intensity, or they don't meet one of those criteria that we mentioned, insurances will often deny rehab. Okay, so that's what inpatient rehab facilities require, or what insurances require on behalf of the patient to be approved for placement in an inpatient rehab facility. All right, number two, the next level of care down is a skilled nursing facility. And so this is a little bit lower intensity as it relates to rehab. And so to qualify for these things under Medicare, the patient must have a 3-day hospital stay, okay? They must need daily skilled nursing or therapy, or both, okay? And the services must require licensed professionals to safely perform them. And so that kind of dovetails with the daily skilled nursing or skilled therapy care, okay? Your nurse or the LPN or the rehab staff, all of them are licensed professionals. And whatever the patient requires, it must only be able to be performed by licensed professionals, okay? And here's an important asterisk. If the patient can improve with less frequent therapy, or they do not need care that can only be provided by licensed professionals, then they may not even qualify for skilled nursing facility care, okay? So if you need to pause that and rewatch it again, either one of those two sections, please do so. The next level of care down is home health, okay? So this is where patients may get redirected if they don't meet the other two levels of care, or the criteria for the other two levels of care. And to qualify for home health, a patient needs to be homebound. Means that leaving home is exceedingly difficult for them, okay? There is some detail related to the laws about what constitutes as homebound, or the criteria of what constitutes as homebound, and so I don't want to get into that here, but suffice it to say that if you're able to go to down the street to your friend's house to play a card game or to have coffee with them, and you can do that of your own volition, you're not homebound. If you can get out of your home with help by being driven by somebody to get to a physician's appointment, and that is very taxing for you, you may qualify as homebound, okay? But let's just suffice to say that the definition of homebound is we should take it at its face, okay? It should be very difficult for you to leave the home, or for your loved one to leave the home. So must be homebound, must require intermittent skilled services. So you're not going to get daily physical therapy, probably won't get daily nursing care when you are at home health. And that is a big caveat here, because from a rehab professional, that is, because there are clear patients that we think often would require daily therapy care. And many times the insurance companies will say, no, we don't think so. We think that this level of care can be provided in the home health environment. And future videos, guys, we may be able to discuss that in more detail as to why I feel that way, and some of the issues that we see around that. But suffice it to say that home health care, physical therapy, and home health care nursing care are going to be intermittent. Right? Therapy is going to be 2 to 3 days at most. Nursing care can be somewhere between 2 to 4 days. Maybe every once in a while 5 days in special cases, but that's pretty rare from what I understand. Okay, this is considered part-time rehab, not full-time recovery support. Okay, so the patient must demonstrate that they do not need full-time recovery support. Let me say it like this: if it's apparent that the patient does require full-time recovery support, then we need to be really working towards, and you need to be advocating for yourself or your loved one to get into either inpatient rehab facility or a skilled nursing facility. Okay, and we're going to cover in some detail coming in the next few minutes as to what you can do to improve your chances at getting approved for either inpatient rehab or skilled nursing level of care. Okay, the next level of care is a little bit special. It's not really in view here because there are very specific criteria to qualify for this level of care, but that's a long-term acute care facility. Okay, this is not rehab really at all. Okay, it's literally long-term hospital stay. Okay, and so this is very highly medically complex care, and they need extended hospital level treatment, extended hospital level supervision of treatment. These patients may be on the ventilator. They may have complex wounds or ongoing complex medical management needs that require them to be, in an acute care environment, but for an extended period of time. Okay, this level is for patients who are way too medically complex to entertain going to rehab. Okay, so just wanted to throw that in there because you may hear about that level of care if you are in the hospital or you have a loved one in the hospital. Okay, so what's important to know here is the key decision that the insurance, or the key question that the insurance is asking, is not, would rehab help this patient? That's not the question they're asking. That may be the question that you're asking, or that the patient may be asking, or that the nurse may be asking, or that the doctor may be asking, or that the rehab staff may be asking. And the honest truth is that, and I'm biased as a rehab professional, I think most people would benefit from going to inpatient rehab after they've been in the hospital. But the reality is, from an insurance standpoint, they may not meet the criteria to go to that level of care. And it's the care team's responsibility to specifically articulate the needs of the patient so that there is little doubt as to what level of care they need. Okay, so the insurance company is not asking would rehab help this patient. They are asking, what is the lowest level of care that is still safe and appropriate for this patient? Please pay attention to that distinction. Rehab is not asking what is best. They are asking what is the lowest level of care that is safe and appropriate. That is a different question than what is best for the patient. Okay? If a patient cannot tolerate 3 hours of therapy, or it seems so in the documentation, and as far as the hospital is concerned, they will be denied inpatient rehab. If they do not appear that they need daily skilled care from licensed professionals, they will be denied skilled nursing. If they are not homebound, they will be denied home health care. And this is, again, we're using Medicare as the primary insurance driver here. We'll get into Medicare Advantage plans in a little bit. So let's go to section 2. Why do patients get denied? Okay, according to to CMS, the Center for Medicare and Medicaid Services, 93.8% of rehab denials are due to a lack of medical necessity documentation in the hospital electronic medical record. Okay, it is not because the patient didn't need rehab, it's because that the documentation wasn't clear and explicit enough to indicate that that patient has a medical necessity for inpatient rehab. Okay, and that tells you something. That tells you that insurances are aggressively reviewing these cases, and the onus is on the care team, that's people like me, okay, to specifically document the impairments and medical necessity that the patient demonstrates that would articulate clearly to the insurance company that the only safe discharge destination for this patient is inpatient rehab or is skilled nursing facility. Okay, and the primary person or group of people that helps accumulate all that information across the care team in the hospital is the case manager and the social worker. At our facility, they are paired in teams, and their job is to take all of the care team information and put it together and see what the entire picture says about the patient's medical necessity. And you need to know that as a caregiver, or if you're in the hospital yourself. Okay, my perspective as a rehab professional in the hospital, or OT, or speech, the physician's perspective, the nursing perspective, or any other specialist or care team member, we are one piece of the puzzle that is the entire care team's perspective. Okay, and you as the caregiver need to be armed with that information so that you can ask questions to the care team, so that you can be sure that they are trying to articulate clearly that what the medical necessity indicates and what this patient's impairments, or what you know, if you're the patient or your loved one is the patient, what do their impairments indicate is the best level of care for them. Okay, so that's important. Moving on to section 3, that is Medicare versus Medicare Advantage. Guys, this is a detailed topic that we will cover at a very high level here. We will not get into the nitty-gritty, but there is a difference. I can't tell you how many people in the hospital have come to me and said, yeah, I have Medicare. Or when we start asking questions about insurance, they say, oh, I have Medicare. And when we look deeper, we find out that they actually have a Medicare Advantage plan. And so that tells me that the general population sometimes are confused about what it is that they actually have when it comes to their insurance provider. So just know that there is a difference between traditional Medicare Part A and B and Medicare Advantage plans. And so here's the critical distinction that families often either don't understand or misunderstand. And that is that traditional Medicare, or with traditional Medicare, no prior authorizations are required to get to the next level of care. Decisions are often based on the CMS criteria that we covered earlier in the video, and reviews happen retrospectively. So that's key. Reviews for that patient's level of care happen retrospectively. So what that means is that the inpatient facility, so the hospital, has the onus of responsibility is on them to determine what the best level of care is for that patient based on the CMS criteria, because often if they discharge that patient to inpatient rehab, there's no pre-authorization needed, and the patient will go to rehab, and then say 60 days later, there's a resource review by Medicare, and it says, hey, this person never should have went to rehab or inpatient rehab in the first place. We're going to deny payment to the rehab facility. And sometimes that can come back to that may be brought to bear on the hospital that discharged that patient to an inappropriate level of care based on CMS criteria. Okay, so that's with traditional Medicare. No prior authorizations are required. Decisions are based on CMS criteria, and reviews often happen after the care has been rendered. And so those patients with Medicare Part A and B often are placed very easily. There's very little time between request for discharge approval to rehab and when they can be approved to go to rehab. A lot of times that happens the same day if the patient has Medicare Part A or Part B, specifically Part A. Now, Medicare Advantage plans, they do require prior authorization. And so it's going to take longer when the physician that's overseeing the care says, hey, you are medically ready for discharge. We're going to try to send you to an inpatient rehab. You have a Medicare Advantage plan. We're going to have to wait for authorization before we send you over there. That's going to delay your discharge. Okay? They use the same criteria as CMS, but can often interpret them much more strictly. So remember that that vague criteria where it says expected to make a measurable functional outcome in a reasonable amount of time. They may interpret that very, very stringently. Okay, and so that's why two patients with the same condition, one with Medicare Part A and B, the other with a Medicare Advantage plan, they can have two completely different discharge dispositions because they have different insurance coverage plans, Medicare Part A versus a Medicare Advantage plan. Okay, so let's move on from that and cover private insurance for a little bit. Okay, major private insurers like UnitedHealth, Blue Cross Blue Shield, Aetna, and so on, they follow Medicare very, very closely. Excuse me while I get a drink here. And so they ask similar questions such as, can the patient be treated at a lower level of care? Do they really need daily physician oversight? Are they making measurable functional gains? Can they improve in a reasonable amount of time? Does therapy need to be done at a skilled nursing facility, or can it be done at home? And so if the answer to any of those questions is a maybe, based on the documentation that's indicated from the electronic medical record, then the private insurance will often attempt to deny higher level of care and opt for a lower level of care. And so what is the real reason that people get denied? Okay, so this is section 5 here. And so the real reason they get denied is, number one, they may be too high level. Okay, they're walking too far with no assistance. Okay, and they appear safe enough to be discharged home to a lower level of care. Okay, number two, they're too low level. They can't tolerate the therapy. Okay, or they're too medically unstable, here's an unpopular one that we see a lot in the hospital. Guys, people feel bad in the hospital. They don't feel great. They often refuse care. Okay, they often refuse therapy. They say, listen, I'm nauseated. I don't feel good. And so if that happens too often in the hospital, the insurance is going to look at that and say, hey, they're refusing care. What's going to happen if we send them somewhere where they're supposed to get more therapy? Okay, so if they're too low level, they're going to be denied a level of care that would indicate that they need to be able to tolerate 3 hours of therapy per day and participate in 3 hours of therapy per day. Okay. Number three, the documentation. This is a tricky one. Sometimes documentation doesn't match the reality of what the patient's presentation is. And so the physician may say one thing and the physical therapist may say another. We have the way that we try to correct that in our facility is we have multidisciplinary rounds, and that's pretty common across multiple hospital systems. That should be happening so that the language can be unified and everybody can know what should we all be saying based on what the patient is presenting like. Okay, and so when therapy doesn't match the reality of the when the documentation doesn't match the reality of the patient, all the insurance is going to look at is the documentation and what it indicates. Okay, they're not seeing the patient. They're not there with the patient. It may be as clear as day for someone like me, or the loved one who's in the room with this patient all the time, or the nursing team, or the physician. It may be as clear as anything that this patient needs a higher level of care. But if the documentation does not indicate that, insurance will deny it. That's just the simple way to put it. Number 4, the insurance thinks that the wrong level or the wrong level of care is being advocated for. And unfortunately, this is a reality in which we live. There can be times when the documentation is clear and they review the case, and allegedly a physician is supposed to review that case, and they say, no, we don't think that this patient meets criteria, even though the documentation looks like it. We think that based on our own chart review that they don't. I can't say I've seen that happen very much, honestly. I have heard about it happening from some physician friends of mine. Suffice it to say that the best bet is always to make sure, from a care team perspective, the best bet is always to make sure that the documentation clearly indicates what the patient requires from a medical necessity standpoint. Okay, so you're asking, okay, this is all great information. Now I understand a little bit better. What's in it? What can I do? How can I improve my chances of advocating for the level of care that I think my loved one needs, or that I myself need? Okay. Here's what you need to know. Insurances care about documented reality related to transfers, fall risk, assistance levels, endurance levels, and safety awareness, not simply what the diagnosis is for the patient. Okay. And the therapy team, nursing team, physician team should all be able to speak to transfers, fall risk, assistance levels, endurance, and safety awareness. I speak to those 5 criteria in every evaluation that I do. Okay. I may say something like, based on the impairments this patient demonstrates at this time and their ongoing hospital stay and medical diagnoses, it is clear that this patient is unsafe to mobilize alone, given their requirement for maximum assistance to perform basic mobility and transfers, their inability to ambulate without maximum assistance, and their elevated fall risk if they were to attempt ambulation on their own. This patient is unsafe to return home because they live alone by themselves and cannot perform the necessary functions to function safely at home, and so on and so forth. I have this whole way that I articulate that in my documentation. And so just know, as a caregiver or as a patient yourself, insurance cares about transfers, fall risk, assistance levels, endurance, and safety awareness. Okay, not just a diagnosis. You need to be consistent, or we need to be consistent across teams. Okay, you need to be asking, are we clearly indicating the level of assistance needed by this patient? Is the physician saying that they're doing, quote unquote, doing well, and the therapy team is saying, hey, they need maximum assistance to do everything for themselves? Well, the physician may be speaking to their medical issues. Yeah, their kidney numbers are better and they're doing well from that standpoint. But we need to be clear in saying, preferentially, what I would indicate or advocate for the physician would say, okay, articulate clearly that their kidney numbers are improving. However, their mobility needs are indicating that they are requiring significant assistance. Please see therapy documentation for more detail, or something along those lines. Okay. And so, because if there's any doubt, if an insurance company if they indicate, if a physician indicates that the physician indicates that the patient is, quote unquote, doing well and is vague in that, the insurance company then has the leeway to read into that the patient is doing well enough to go home possibly, or go to a lower level of care. So you need to advocate for consistency across care team members. Okay. Here's a very unpopular one sometimes. I can't speak today. And that is that you can use the appeal process. You have the right to appeal your discharge disposition if you think that you are not receiving the appropriate discharge disposition or destination. Okay? Denials are not final. Many cases are overturned with peer-to-peer reviews, additional documentation clarity or clarification, and further clarification on functional deficits. And so I know our therapy team had to be encouraged, and me being the rehab supervisor in our department, we had to encourage some of our therapists to become a little more explicit in their documentation, given the challenges that we were having on getting patients approved to their appropriate level of care. And so, excuse me, here's the reality of the situation. We're going to reiterate some things here, okay? Insurance is not asking, would rehab help this patient? I mentioned that earlier, okay? They're not asking what is best. They're asking, is inpatient rehab or some other significant level of care, like skilled nursing, are those the only safe and necessary option? And guys, that's the burden that the care team must take on. We must, and you must advocate for, as a patient or as a caregiver, you must advocate for the care team to be as explicit as possible so that it is clear beyond hardly any doubt that the only safe and necessary option for this patient is to go to inpatient rehab or go to skilled nursing, to a skilled nursing facility. Okay, and that's a high bar. I'll be honest with you. It requires a lot of detail. Okay, so if you're in the hospital right now, or you are a caregiver of someone in the hospital, and you're trying to process some of this information, okay, I hope this video helped you. I really do. Comment, appeal in the comments. If you're trying to actively work through an appeal, reach out to me with a question in the comments if you need to. I may be able to help you a little bit. I may be able to help you know kind of what questions to ask, given that there's contextual specificity that needs to be taken into consideration with each patient case. Okay, so guys, I just want to help give you the tools to fight the fight of battling insurance companies. Okay, they're not evil in and of themselves. Okay, the system is just very difficult to deal with. That's putting it nicely. Okay, and it's difficult on purpose, but with some concerted effort and trying to not being afraid to advocate for yourself or for your loved one, we can go a long way in getting patients approved for the level of care that they need. Okay, if you're in a facility where you feel like you're the only one advocating for your loved one, you might be, because I see it every day in the hospital. Some case managers and social workers and nurses and therapists and physicians, they get frustrated dealing with situations like this when they're just trying to do what's right for the patient, and they keep running in roadblock after roadblock. They can get burnt out on it. And so it may take you asking a pointed question, or and in a polite way. It doesn't have to be very inflammatory, and just say, hey, we're really trying to work towards getting this my loved one or myself to the appropriate level of care. Can we just make sure we're doing these things, and go back and reference some of those criteria that I said earlier in the video. Okay, so again, guys, I'm just out here trying to help bring my perspective and my 12 plus years of experience in the hospital environment. I'm just trying to help you folks. All right, so in the next video, what I'm probably going to do is I'm probably going to go through a specific kind of appeal process, kind of go through some information that you can use in an appeal process if you find yourself calling your own insurance company and saying, we're going to appeal this denial that you have, and here's why, and kind of give you some tools to work through, to hopefully equip you to go through that appeal process with some ammunition. Okay, so stay tuned for that next video. Hope you stick around. Subscribe to my channel if you're in this for the long haul. We have a lot more information to cover. Okay, I skimmed over this insurance information. Okay, because every situation is specific. Okay, health insurance is convoluted to say the least. I'm not an insurance lawyer at all. I just deal with it every day from a provider standpoint, and I see the problems that patients have, and so I'm just trying to offer some assistance and some perspective to those out there that are finding it a struggle to deal with the insurance landscape in general. So if you have any other specific questions related to insurance questions, or any other concerns or questions related to insurance coverage and so on and so forth, leave them in the comments. Okay, and I know some case managers and social workers personally that I can get some information from, and I will do my best to get that information to you in short order. Okay, take care. Hope you stick around for more content on this channel. We're gonna be here for a while, so hope you will be too. Take care, and I'll see you on the next video.